The veteran suicide rate is currently 1.5 times the rate of the general population, and the United States Department of Veterans Affairs says its top clinical priority is preventing suicide among all those who have served.
Now, years later, I would say the military and veteran community are absolutely on the leading edge of this. The veteran community I have found to be way more open to this issue. And I think it's because so many of us have lost friends and loved ones, and we're sick and tired of it. And we know that it's a gun-related issue, and we know what gun safety is.
Clinical psychologist Dr. Craig Bryan is an Iraq War veteran and the author of Rethinking Suicide: Why Prevention Fails, How We Can Do Better. His research is revealing new insights about what's leading to suicide and the role that firearm safety can play in preventing more deaths.
More than half who die by suicide do not have a known mental health condition or mental illness is actually something that is known about suicide as a whole. The same is true amongst civilians. And so in that sense, there's a similarity amongst veterans and non-veterans in terms of risk factors. And what this means is that I think a lot of our historic approaches to how we understand we could best prevent suicide, at least in the United States, is really focused on mental health treatment, mental health screening, things like that. And I think what the statistics there would suggest is that might be useful for helping out some veterans, but not many others.
This is Conversations on Healthcare.
Welcome, Dr. Craig Bryan, to Conversations on Healthcare.
Oh, thanks so much for having me.
Yeah. And, before we dive into your research, let's start with an overview. Veterans are 72% higher risk of suicide than those who haven't served. This is a reversal from earlier trend. For instance, prior to 2001, veteran suicide rates were far lower than those in the general population when comparing age groups. Suicide is also the second leading cause of death among veterans under 45. And finally, the female suicide rate for female veterans is 166% higher when compared to their civilian counterparts. I'm wondering, what do we know about the story behind these statistics, and why are we seeing such suicide increases right now?
Yeah, we think that all of these trends are related to a multitude of factors. There's, not one single contributing cause. But we know, for instance, that some of these contributors are that the veteran population as a whole is aging. We know that the majority of veteran suicides, as in the highest number of deaths, occur amongst veterans above the age of 55, who are now typically more of like Korean War and Vietnam War era. That maps onto a little bit what we know amongst U.S. suicide rates as a whole. The highest rates are amongst older adults. And so we think that it's a combination of an aging veteran population, at least for those who served several decades ago. And on top of that, you're going to have a lot of health-related issues, higher rates of disability, higher rates of psychological conditions, and all of these things we think maybe come together to increase risk within the veteran community as a whole.
I'm wondering if it was the number of conflicts that we had since 2001, obviously, 9/11 and lots of subsequent engagement around the globe. Seem to be more veterans. I'm wondering if that also played a factor.
Yeah, that was one of the early hypotheses, not long after 9/11, especially around 2006 or 2007, when the military rate started to increase. Interestingly, a lot of research has been done on this and has generally not been able to support that conclusion. And what we're seeing, for instance, is that the majority of service members since 9/11 who died by suicide were what we call first termers. They had just joined the military. They were at their first duty assignment. And so those with a deployment history were not necessarily disproportionately more likely to die by suicide. And so it took many, many years, but after about a decade of research, it really seemed like that might not actually have been a major contributor, and maybe there were some other issues at play that honestly I don't think we've fully figured out yet.
Well, we note in some of your work and what we've read that over half of veterans who die by suicide don't have a known mental health diagnosis or mental illness, according to the Department of Veteran Affairs. I found that a little bit surprising to read, but the VA goes on to say that even though mental health issues can be a factor when it comes to suicide risk, it doesn't paint the full picture, which goes to what you're saying about many factors. I wonder if you can speak to the issue we've been reading about people who are perhaps exposed to traumatic brain injury risk just from constant exposure to testing artillery and issues like that. Has that been identified as a contributing factor?
Yeah, so a couple of points I think related to that statistic. So that number that you just cited for veterans, more than half who die by suicide do not have a known mental health condition or mental illness, is actually something that is known about suicide as a whole. The same is true amongst civilians. And so in that sense, there's a similarity amongst veterans and non-veterans in terms of risk factors. And what this means is that I think a lot of our historic approaches to how we understand we could best prevent suicide, at least in the United States, is really focused on mental health treatment, mental health screening, things like that. And I think what the statistics there would suggest is that might be useful for helping out some veterans, but not many others. And so we perhaps need to have a broader perspective on things. And I think one of the things you note there, traumatic brain injury. So this is something that has been identified as another risk factor for suicide that increases risk independent of mental health conditions. I published some research years ago when I first got out of the military around this, showing that service members who had a history of multiple traumatic brain injuries over the course of their lives were at increased risk for suicide. This has subsequently been shown to be true in the veteran community more broadly, as well as non-veterans. And it seems to be something that over the course of the entire lifespan, it might include sports-related injuries, car accidents, slips and falls, but also work-related injuries and accidents, perhaps explosions, blast exposure, but also other mishaps that sometimes occur and are oftentimes more common in the military. Another common source of head injuries in the military that it's often overlooked is combatives training. Just hand-to-hand self-defense. A lot of people get knocked out while you're learning martial arts, things like that. And so there is this, I think, unrecognized and underappreciated risk for veterans that, this injury, these head injuries, oftentimes come part and parcel with the career field itself.
Dr. Bryan, I want to talk a little bit about access to mental health services. And I know there was a study, Blue Star Family Survey, that found 1/4 of active duty U.S. military personnel say they are not receiving mental health care but would like to. I'm wondering what more can be done by the armed forces to provide mental health services. And we're certainly seeing post-COVID an enormous demand for mental health services, really a lack of staffing for the demand. But specific to the armed forces, what's your thought about ways that they can expand mental health support to veterans?
Sure. Yeah, so a couple of years ago, Secretary of Defense Austin commissioned an independent review committee to focus on suicide prevention and response in the Department of Defense. And access to care, mental health services was a major section of that report. And some of the findings of this independent review commission were that, of course, we have a national behavioral health shortage. And so just across the United States, we don't have enough counselors and therapists and psychiatrists. And of course, that's affecting the military as well. There's also been a move, particularly within the military, to increase screening for suicide risk and for other mental health concerns. And unfortunately, decades of research has shown that a lot of the screening tools that we use tend to identify the wrong people. And so it ends up creating this backlog of demand for mental health care services. And that was one problem identified by this independent review committee, is that in essence, we're using screening methods that perhaps are not particularly effective, and we are flooding the zone. And so it's hard to get in for an appointment. And so what this means is that perhaps we need to be much more judicious about how we go about mental health screening within the military. And then I think a third related issue that's not Department of Defense specific, but perhaps is more broad within the federal government and society, is that right now a lot of veterans are not eligible to receive mental health services from the VA. It's a dirty little secret that most Americans don't know, is that under congressional law, the majority of veterans cannot receive health services from the VA. And so part of the reason why more veterans don't get help is because by federal law, they're not allowed, or at least their services are not covered by our tax
Walk
dollars.
through that a little, because that may be new to some of our listeners.
Yeah.
New to me.
Yes. Yeah, exactly. Yeah, new to a lot of people. Like I said, it's surprising. I think a lot of us had this assumption, right, that, well, you serve in the military and then you get out and you go to the VA for your healthcare. That's actually not true. There are all these rules. It's this very, very convoluted, confusing process, which is why we often hear about, veterans complaining about the review process to get approved for healthcare benefits. There are rules on your discharge status. So if you have an other than honorable discharge, federal law says you don't get services from the VA. There's even income limits. And if you historically did not have a medical condition or health problem that was directly related or caused by military service, in essence, Congress said, no, we're not going to provide benefits, healthcare coverage for you. So now that has changed a lot in the past year or two. There have been a lot of movement to open the door for more veterans. The PACT Act and the Compact Act are two different efforts. And I call attention to this because I've been out of the military myself for like 15 years, and it was only 6 months ago that I became eligible for VA services and had my first VA medical appointment. And so I think there's positive movement. We need to continue that momentum, but that is 100% a congressional issue. And so my hope is that one of the things your listeners and viewers will take away is that that's something you should be talking with your legislators about.
Absolutely. Well, thank you so much for sharing with us. I think that really is news to a lot of people. And as you say, certainly the development of the community-based primary care centers for veterans has helped with that, but you have to have the eligibility piece to go with it. Craig, I want to talk about your work, or give you a chance to talk about your work a bit in developing a brief form of CBT, cognitive behavioral therapy, to use for suicidal military personnel, and you have some evidence to suggest that this can significantly reduce suicide attempts. So tell us about that. How brief is brief? Does it allow for a telehealth approach as well as an in-person approach? Tell us more about this.
Yeah, so brief in this case, the average or the typical duration of the treatment protocol is 12 sessions or 12 appointments. And, in most cases, therapy or counseling is scheduled, 1 hour appointment every week. And so you're typically looking at maybe a three month commitment for the therapy, which is much briefer than a lot of historic traditional forms of psychotherapy that can be sometimes years in duration with multiple sessions per week. And so it's a really significant advance that, in essence, within 10 to 12 hours of outpatient therapy, we can lead to 60% reductions in suicide attempts. It's remarkably effective. We've tested this with military personnel and published those results. We've since done follow-up research. And we have several new studies that we anticipate being published in the coming year. They're currently under review or in different stages of the publication process. But what we're finding is we're reconfirming those initial results. And one of the studies that we have just finished up, to answer your question about telehealth, that was what we did. We tested, can we deliver the therapy effectively and safely, virtually, over an online video-based platform? And the answer is yes, absolutely. It works. It reduced suicide attempts by 50%. And now, actually, a big part of the work that we do here at The Ohio State University, we have a specialty clinic that does nothing but suicide-focused care for all adults who are experiencing suicidal thoughts. And around half of the therapy that we provide is virtual, where people are not actually coming in to our building, to our clinic face-to-face. We're connecting with them online in their homes, in their communities, wherever they happen to be.
You know, Dr. Bryan, in your advocacy, you speak truth to power. And I want to quote something that you wrote in the Hill newspaper. Little to no progress in suicide prevention will be made until we directly address the central role of firearms. Nearly 70% of military suicides in 2020 were caused by self-inflicted gunshot wounds, and almost all of them were from personally owned firearms. So I'm wondering, how do you navigate the sort of tricky politics of gun rights and your suicide prevention goals?
Yeah, this is, I've classified this topic sometimes or characterized it as the third rail of suicide prevention. And it's because these interesting statistics, like you just cited here, almost 70% of military and veteran suicides involve firearms. We know that by and large within the United States, when we look at gun-related deaths as a whole, 2/3 of them are suicides. And so the topic of suicide and the topic of gun violence, I guess, are these overlapping circles, right? And it's almost impossible to have a meaningful discussion about either of those things if we don't talk about gun suicide. And so a lot of the work that we've been doing with the military over the past decade has actually been very eye-opening. I think when we first started moving into this space 10 or so years ago, everyone's initial reaction is this is a no-go issue. It's a non-starter. You're just going to piss everyone off. And so why even do this? Now, years later, I would say the military and veteran community are absolutely on the leading edge of this. The veteran community I have found to be way more open to this issue. And I think it's because so many of us have lost friends and loved ones, and we're sick and tired of it. And we know that it's a gun-related issue. And we know what gun safety is. And many of us, were trained at firing ranges, and we qualified annually or more frequently. And we had all these safety rules when we go to the range to make sure people don't get hurt and stay safe. And then a lot of what we talk about now is to take those rules about secure storage and now just take them to our homes and be just as responsible at home as we are at the firing range. And so the way that we have approached the issue of firearm suicide is to say, we need to lock up our guns at home. Because in the same way that we lock up our cars or we lock the front doors of our homes to help deter unwanted behaviors from coming, we can lock up our guns in the same way, which will deter some people in the heat of the moment when they're really overwhelmed. That extra step of having to unlock their gun can be enough to actually save their lives.
Craig, you've highlighted the Department of Defense has implemented several firearm injury prevention strategies, one of which is the distribution of firearm locking devices. But you also point out a severe limitation that Congress has enacted. So tell us about that.
Yeah, there was, as part of the NDAA, I don't know, it was maybe 10 or more years ago, something like that. Can't remember what year it was in now. There was this provision that was included that had language that in essence said something along the lines of that the Secretary of Defense shall not keep records of which service members own personal firearms, how they store them, things like that. And so that was subsequently interpreted as you're not allowed to ask about guns. You're not allowed to really address gun-related safety. And so this has created a significant barrier for not only commanders and leaders to try to promote safety within their units and ranks, but it's actually been a big obstacle for researchers. We were doing some studies several years ago, for instance, where we've been trying to understand, how do service members store their firearms at home? What do they prefer? What are they willing to do? And what would motivate them to be safer around this topic? And we had a hard time getting, the approvals to ask those types of questions because of this one particular rule. And so a lot of time and energy and resources have been spent trying to promote firearm safety and secure storage without actually asking about it, without using certain language. And it was this politically contentious issue that, again, the initial intent was to protect the Second Amendment rights of service members. So it was well-intentioned. And then, as is often the case, many, many years later, people interpret the rules and the language in a certain way, and it actually has served as a barrier to helping to prevent suicide.
I want to just remind our audience that anybody who's got any concerns or is contemplating suicide or having real mental health issues, that they can dial 988. This is a suicide and crisis lifeline. And I'm wondering, Dr. Bryan, do explain how this lifeline is specifically helping veterans who call in.
Yeah, so the lifeline, if you call 988, which is a national lifeline, it used to be this really long 1-800 number that no one could remember. And so a few years ago, due to federal legislation, we were able to enact 988. So it's so much easier to remember. Military personnel veterans, when they call 988, they have the option after the system picks up to press 1. And it actually redirects to call centers in New York as well as Atlanta, Georgia, of VA-trained crisis counselors. And some of the benefits of this is, aside from being able to listen, to help the caller, to try to walk them through whatever they're experiencing right now and listening to them with empathy, because of the link with the VA, there's also an opportunity in some cases for a veteran to be connected with an appointment, to have other assistance in providing and receiving healthcare services as well. And so we see it as a really important part of the overall suicide prevention strategy. And it's something that I make sure that all the veterans that I work with as my patients, that they have access. We write it down on a card so that, if they have a dark moment, especially oftentimes it happens in the middle of the night when doctors aren't awake and family members oftentimes aren't awake. There is someone who's awake, and they will answer the phone and they'll listen.
This maybe ties to that, but I really appreciate that part of your research involves studying people who've survived a suicide attempt. And I wonder, in your research, are there any themes that you've taken from those conversations and that research, either in terms of underlying mental health concerns or pre-existing issues, or as you say, the phenomena of help's not around necessarily in the moment when you need it? Tell us a little bit about what you're seeing.
Yeah, I would say, I've learned a lot, so it's hard to kind of pick one, but I would say right now, perhaps one of the takeaways of listening and learning from suicide attempt survivors is really how often the urge comes very rapidly. And I think we have historically, I think, talked about suicide as this incremental process where, people, they get upset and then they wish that they were dead, and then they think about killing themselves, and they start to make a plan, and then they start to prepare, then they give away items and things like that, and then they attempt. But what we have found is that probably more than half of those who attempt suicide describe what we now refer to as rapid intensification. They go from a low risk to a high risk state very fast, within minutes to hours. And so oftentimes, if there are warning signs, people, family members, friends, loved ones, oftentimes are not around to see it because it happens so fast. And so this has really, I think, fundamentally shifted how I personally think about suicide and what this means about how to best prevent it. Because I think if we rely only on, here's like a whole bunch of warning signs, and if you see people do these things or you hear them talk about these things, get them to a hospital, something like that. We're going to miss the majority of veterans who die by suicide. We will continue to. And then you throw on top of that, you sprinkle in the mix that rapid intensification of risk and easy access to a highly lethal weapon, a loaded weapon. And that's a perfect storm for a bad outcome. And so this, I think, is another reason why we've really emphasized and really stressed and heard from survivors that things like secure firearm storage, locking up your medications, taking other steps to create a safer environment, in some cases will save their lives. Same way that we buckle up our seatbelts when we get into our car because we never know when we're going to get into an accident.
Right.
It happens suddenly. And it won't prevent the accident, but when you wear that seatbelt, it can save your life, and secure storage can do the same.
Dr. Bryan, I'd like to pull a little more on the research that you obviously have a really great handle on it, particularly about World War I veterans who were suffering from shell shock, the term they used for what we now call PTSD. Is there something different about the war today that's leading to higher suicide rates?
Yeah, that's a good question. I guess the honest answer is we don't fully know. But I do know one thing that is different now that maybe is related or consideration is way more service members survive their injuries now than was the case in World War I. And so as a result, many veterans have lifelong disabilities, physical limitations, and despite the ADA, the Americans with Disabilities Act, the world in which we live is not built for people with mobility limitations, right, and other disabilities. And so it can be a very challenging experience. And so we see a much higher percentage of surviving veterans with long-term injuries and wounds and medical conditions that 100 years ago would have killed people. No one would have survived.
And it's so strange.
And so it's a difference.
We've seen the improvement in terms of emergency room service because of what's happened in the military environment, right? All of those have transitioned over to your local emergency room, which is probably saving veterans. And what a terrible knot here that's gotten tied between those two factors.
Yeah, absolutely. And I mean, it's the medical advances, it's, evolution of like body armor, other protective equipment as well that has come together. But I think your point about, the lessons learned on the battlefield then come back and often benefit all of us who are in severe motor vehicle accidents or house fires and other horrific experiences like that. I feel compelled to even kind of tie a thread where we've had similar translational knowledge on the psychological injury front. And so one of the ways that my research and my team has really pushed forward in treating PTSD is to use an approach that is referred to now as masked therapy, masked as in like crammed together and compressed in a short time frame. And so the historic way of doing therapy for someone with PTSD is we meet once a week for months, on end, and hope that things get better. And what we do in the masked format is we meet every single day for 2 weeks. And so we just compress the therapy into a short window. The idea from this came from the battlefield. Because when many of us psychologists were deployed to Iraq and Afghanistan, we did not have the luxury of scheduling a Tuesday appointment every afternoon for the next few months. We had to make decisions fast. We had to help people return to the fight or go home. And so we started cramming the therapy into these really short windows, meeting with injured and traumatized service members daily, multiple times a day, and we found that it worked. And a lot of us military psychologists brought that idea back to the United States, and it's now considered to be one of actually the more effective ways to treat all people with PTSD, veterans and civilians.
Well, Dr. Craig Bryan, we want to thank you for joining us for this important conversation. I think we could continue for quite a while with additional questions, but we're grateful to our audience as well for being here. Be sure to subscribe to our videos on YouTube, find us on Facebook and X with our account name CHC Radio. And as always, you can go online to chcradio.com to sign up for email updates. And please share your thoughts and your comments about this program. Craig, thank you so much for your service, for your research and really groundbreaking efforts. And thank you for joining us today on Conversations.
Thank you.
This copyrighted program is produced by Conversations on Healthcare and cannot be reproduced or retransmitted in whole or in part without the express written consent from Community Health Center, Inc. The views expressed by guests are their own, and they do not necessarily reflect the opinion of Conversations on Healthcare or its affiliated entities.